Facial paralysis is a relatively common affliction. Facial paralysis creates cosmetic and functional deficits that may be extremely troublesome. Usually, the condition involves one side of the face. If the muscles cease working altogether, the condition is facial paralysis. If the muscles are merely weak, the condition is facial paresis. For the rest of this discussion, we will use the word paralysis to refer to complete paralysis or severe paresis. This condition results in drooping of one side of the face, inability to close the eye, which exposes it to dryness and injury, and incompetence of the corner of the mouth, which may cause drooling of liquids and difficulty articulating some sounds. One of the principal problems in management of facial paralysis is a widespread tendency within many sectors of the medical community to under-evaluate the problem and to misdiagnose it. In 1821, Sir Charles Bell studied the innervation of the facial musculature and named the motor nerve of the face the facial nerve. Soon, all conditions of facial paralysis came to be known as Bell's palsy. As time passed, the true cause of many cases of facial paralysis was discovered. Bell's palsy is now the name used to describe only those cases of facial paralysis in which the cause cannot be determined. Unfortunately, many physicians still diagnose Bell's palsy without going through the comprehensive evaluation necessary to diagnose and treat important causes of facial paralysis. A proper evaluation includes a complete history, careful physical examination of the ears, nose, throat, neck, and parotid glands, at least a partial neurological examination, imaging studies, usually CT scan and MRI, hearing tests, electrical facial nerve tests, and blood tests. These tests are designed to detect the true cause of the problem. If none is found, the condition may properly be called Bell's palsy. Bell's palsy patients always recover, at least partially, although recovery may take as long as a year. If the face remains paralyzed without recovery of facial function, the diagnosis of Bell's palsy is generally wrong, and the true etiology should be sought again. When examining patients with facial paralysis, the severity of their paralysis should be recorded using a standardized grading system. The House-Brackman grading system is used most widely. The grading systems are actually easy to remember. Grade 1 is normal. Grade 6 is completely paralyzed. Grade 2 is almost normal. Grade 5 is almost completely paralyzed. The difficult distinctions come between Grade 3 and Grade 4. In Grade 3 out of 6 facial paresis, the paralysis is obvious, but there is still some motion in the forehead and the patient can close his or her eye completely with effort. In Grade 4 out of 6 paresis, the patient can no longer obtain complete eye closure, and the forehead is paralyzed. The objective of this test is to match the grade of paralysis to the correct diagnosis. The motor fibers of the facial nerve originate in the facial nucleus in the brainstem. They course from the facial nucleus, bending around the abducens nucleus, and course from the brainstem across a short expanse of posterior fossa and enter the internal auditory canal. Sensory fibers course from the internal auditory canal to enter the brainstem. The facial nerve carries special sensory fibers for taste, preganglionic parasympathetic fibers to the lacrimal and submandibular glands, and sensory fibers to the skin of the posterior superior aspect of the external auditory canal. Decreased sensation in this region is called a positive Hitzelberger sign and is common in the presence of lesions that cause pressure on the facial nerve, such as an acoustic neuroma. In the internal auditory canal, the facial nerve travels in close proximity with the acoustic nerve. The facial nerve is located in the anterior superior compartment of the internal auditory canal. It becomes covered with bone in its labyrinthine segment as it leaves the internal auditory canal. It then courses anteriorly, bends at the geniculate ganglion, the second genu, although it is commonly referred to incorrectly as the first genu. It courses horizontally and vertically through the mastoid, and it exits through the stylomastoid foramen and innervates muscles of facial expression. It gives off several branches within the temporal bone that can be tested, including the greater superficial petrosal nerve, which supplies preganglionic parasympathetic fibers to the lacrimal gland for tearing, the nerve to the stapedius muscle, and the chorda tympani nerve, which supplies taste to the ipsilateral two-thirds of the tongue, and preganglionic parasympathetic fibers to the ipsilateral submandibular gland. The details of a comprehensive ear, nose, and throat examination, cranial nerve assessment, and audiometric testing will not be reviewed in this discussion. They are similar to those assessments performed in patients with hearing problems or suspected facial neuroma. Metabolic evaluation for diabetes, hypothyroidism, Lyme disease, and the many other conditions mentioned later in this discussion should also be performed. Radiological assessment is also similar and generally includes MRI with enhancement of the entire course of the facial nerve from the brainstem through the temporal bone and into the parotid gland and facial muscles. Temporal bone CT also may be helpful in showing areas of bone destruction or injury that may compromise the facial nerve. Special clinical examination of the facial nerve and facial nerve electrical testing warrants further discussion, however. Facial nerve testing is done routinely when a motor abnormality is observed. However, tests may also be helpful in the absence of obvious motor abnormalities, especially if a pressure lesion is suspected, such as acoustic neuroma or vascular loop compression. The validity and reliability of topognostic facial nerve testing have not been proven. Nevertheless, they often provide helpful information regarding the site of a facial nerve lesion. A modified Schirmer tear test helps determine whether the lesion is proximal or distal to the greater superficial petrosal nerve and auricular ganglion. The stapedius reflex decay test establishes this relationship to the stapedius muscle. Testing of taste sensation on the anterior two-thirds of the tongue or testing salivary flow from the submandibular glands locates the lesion in relation to the chorda tympani nerve. Peripheral branches of the facial nerve can be tested with a facial nerve stimulator. Although minimal nerve excitability testing is performed, most commonly, maximal nerve excitability may provide more information. It usually requires 1 or 2 milliamperes of current above the nerve threshold. Assessment of all of these tests is subjective. Standard facial nerve electromyography, EMG, records muscle action potentials produced by voluntary efforts to move muscles. Responses are recorded using needle electrodes inserted into the muscle, and the signal is monitored on an oscilloscope visually and acoustically. Neuromuscular function and degeneration can be detected. Electroneuronography, ENOG, is similar to electromyography except that it uses surface electrodes and evoked rather than volitional stimuli. A stimulating electrode is placed over the main trunk of the facial nerve at the stylomastoid foramen, and a recording electrode is placed over the muscle to be tested. This technique allows a measurement of latency and conduction velocity, although latency has proven a more useful measure. Recording of threshold is possible. However, supramaximal stimuli are used generally. Several parameters can be measured and have proven useful clinically. Electroneuronography is a measure of the facial nerve action potential and is quantified in terms of amplitude as measured in millivolts. A comparison is made between the nerve response on the poor side versus the good side, and a percent weakness is calculated for the poor side. A difference of 17% or more between the two responses is considered significant. What kind of problems may cause facial paralysis? There are many, and this discussion will provide a brief overview of only a few of them. Facial paralysis can be congenital. That is, some people are born with paralysis of one side or both sides of the face. This problem may result from various causes. Acquired facial paralysis is much more common. Infection and inflammation are well-established causes. The infection may be viral, particularly herpetic, and is often associated with a herpetic cold sore or fever blister. Herpes zoster, shingles, may also be etiologic. This problem may also involve the hearing nerve, which runs in close proximity to the facial nerve. Viral or bacterial infections of the ear, otitis media, the brain, meningitis, Lyme disease, from ticks, and HIV infection also cause facial paralysis. Facial paralysis has also been associated with toxic effects from exposure to heavy metals, such as lead, and immunologic response following injections for tetanus, rabies, and polio. Metabolic conditions, including diabetes, hypothyroidism, and pregnancy, may precipitate facial paralysis. Vascular problems associated with vasculitis, some of which may accompany collagen vascular syndromes, diabetes, and other conditions, may also be associated with facial paralysis. Trauma is also an important cause of facial paralysis, particularly temporal bone fracture associated with motor vehicle accidents or falls, and surgical trauma. Facial paralysis is a potential complication of ear, brain, or parotid gland surgery. In addition, facial paralysis may be the first presenting sign of a tumor. The tumor may be benign or malignant. It may occur anywhere along the course of the facial nerve, which starts in the brainstem, courses circuitously through the ear encased in a tight, bony canal, exits the mastoid bone at the skull base, and spreads out along the face. Tumors of the facial nerve itself, facial neuromas, commonly present with facial paralysis. So do cancerous tumors of the middle ear, parotid gland, and upper neck. Facial paralysis occurs rarely with acoustic neuromas, despite the fact that compression of the facial nerve by these tumors is common. Other growths of the temporal bone that may cause facial paralysis include cholesteatoma, glomus tumor, and neuromas of other nerves. Facial paralysis may also be caused by neoplasms outside the temporal bone. When a parotid neoplasm presents with facial paralysis, the lesion is almost always malignant. A variety of other conditions may be associated with facial paralysis or paresis, including hemifacial spasms, which may be due to vascular loop compression of the facial nerve, Melkerson-Rosenthal syndrome, barotrauma, sarcoidosis, and of course Bell's palsy. However, because facial paralysis may be due to many serious conditions, physicians should not accept a cavalier diagnosis for Bell's palsy, but should pursue a credible diagnosis based on systematic comprehensive evaluation. Tumors and many of the other conditions we have mentioned may be treated effectively, particularly if they are diagnosed early. Treatment for facial paralysis depends upon the cause. If a specific disease or tumor is identified, it is treated appropriately, and in many cases, facial nerve function can be restored. Regardless of the cause, symptomatic treatment is important, particularly eye protection. The eye should be treated with artificial tears and/or a more long-lasting artificial lubricant. At night, the eye should be taped shut, with tape running horizontally along the upper lid toward the side of the face. The tape should not cross the lash line. When it does, it may invert the lashes and scratch the cornea. Corneal problems are of particular concern when there is a poor Bell's phenomenon. The eyeball does not rotate up when the eye is closed, or when there is simultaneous fifth cranial nerve pathology resulting in decreased corneal sensation. In these cases especially, it is important to protect the eye aggressively, usually surgically. This may involve implantation of a gold weight, surgical tarsorrhaphy, and/or medial or lateral canthoplasty. Surgery is always a last resort. However, it should be considered if electrical excitability decreases by 90% or more, if facial paralysis is sudden, total, and associated with severe pain, and in selected other situations. If no cause is found and the condition is truly Bell's palsy, various treatments are available. The medical specialists most involved in caring for Bell's palsy are neurotologists, subspecialists of otolaryngology, ear, nose, and throat, who deal with disorders of the ear and related structures, including the facial nerve and the ear-brain interface. Neurotologists also commonly evaluate patients with facial paralysis, but few specialize in this particular nerve. Most of us specializing in facial nerve disorders base our treatment recommendations for Bell's palsy on electrical testing of the facial nerve called electroneuronography. Treatment may involve observation, use of high-dose steroids, cortisone products, or surgery. In general, if recovery from facial paralysis begins within 3 weeks, recovery is excellent and total. If recovery does not start until after 3 months, it is usually imperfect. In these cases, the nerve usually develops some degree of synkinesis, inappropriate neuromuscular function. This is caused by recovering nerve fibers growing down the wrong channels. This results, for example, in a slight smiling of the lips when the person closes his or her eyes. Crocodile tears and gustatory sweating result similarly from misdirected nerve fibers that should have gone to salivary glands. Hence, when the person eats, tears fall from the eyes, and the side of the face perspires. These problems can often be minimized with early, accurate diagnosis. Because any disturbance of facial function is potentially so problematic, it is essential for any physician encountering this affliction to follow through with the comprehensive evaluation appropriate for this potentially serious disorder. Simply looking at a paralyzed face and proclaiming it Bell's palsy is not in keeping with the current standards of care.